How I use aspirin to unclog arteries. This journey into understanding aspirin, a minuscule pill that has remarkably influenced public health, begins with its astonishing ability to prevent blood clots, thereby averting potentially fatal events like heart attacks. This tiny dose, which might be barely visible in the palm of one's hand, has historically been credited with saving an estimated 100,000 lives annually, a testament to its profound impact on cardiovascular health. Its primary mechanism in this life-saving role lies in its capacity to inhibit the formation of arterial clots, the very structures that can obstruct blood flow and precipitate a heart attack or stroke. Yet, despite its venerable history and proven efficacy, a perplexing trend has emerged in recent years. A significant number of individuals have ceased taking this widely available, seemingly innocuous medication. The question that naturally arises is, why the sudden cessation? Is aspirin not considered relatively safe, especially given its status as an over-the-counter remedy accessible to virtually anyone? The answer, as it turns out, is far more nuanced than simple safety concerns, involving a pivotal shift in medical guidelines that sparked widespread confusion. A major turning point occurred in 2022 when the U.S. Preventive Services Task Force, USPSTF, a respected authority in evidence-based medicine, revised its recommendations concerning aspirin for the primary prevention of heart attacks and strokes. Their updated stance was clear. Aspirin is no longer universally recommended for everyone, particularly for those without established cardiovascular disease. This pronouncement immediately raised eyebrows and led to a wave of misunderstanding, prompting many to question why a drug so readily available and effective in saving lives was suddenly being reevaluated. The core of this widespread confusion, as we will unravel, lies in distinguishing between appropriate and inappropriate uses of aspirin, especially in light of evolving medical understanding. We will meticulously clear this ambiguity, delving into the precise scenarios where aspirin can be a formidable tool to clear arteries and prevent cardiovascular catastrophes, and equally importantly, when its use might be ill-advised or even dangerous. Furthermore, we will explore a range of alternatives, encompassing both conventional medications and natural supplements that serve as blood thinners, offering a comprehensive perspective on clot prevention strategies. One particularly critical area where the aspirin story becomes complex is in the context of atrial fibrillation, AFib, a common heart rhythm disorder. Understanding AFib, what it is and why it holds such vital importance in the discussion of aspirin, is paramount, as it represents a scenario where aspirin is emphatically not the appropriate choice for prevention. We will dissect why this is the case, shedding light on the distinct mechanisms of clot formation in AFib that render aspirin ineffective. Additionally, we will introduce another crucial player in cardiovascular risk, LPA, or lipoprotein A, exploring its nature and its intriguing wrinkle in the broader narrative of aspirin's utility. For those embarking on this detailed exploration, it's advisable to settle in with a preferred beverage, ideally in a steel cup or glass to avoid plastics, as we embark on this enlightening journey. My name is Ford Brewer, and I approach this topic from the unique perspective of a preventive medicine physician, a path I gravitated towards after my initial career as an emergency room doctor. The experiences in the ER, witnessing countless individuals suffering from heart attacks, strokes, and other preventable conditions, situations that coulda, woulda, shoulda never happened, profoundly impacted me. This stark reality ignited a passion for prevention, driving me to transition into a field I hadn't initially envisioned for myself. With 4 decades of experience dedicated to preventive medicine, I bring a wealth of practical and clinical knowledge to this discussion. To grasp the full scope of aspirin's role, we must first establish 3 foundational understandings. First, what precisely is aspirin? The second essential piece of knowledge is how aspirin actually works within the human body. And finally, and perhaps most critically, we must thoroughly examine its potential side effects and challenge the common misconception that it is an entirely harmless substance. Let's begin with aspirin's origins. The year 1897 marked a significant moment in pharmaceutical history when Felix Hoffmann, a chemist working for the German company Bayer, successfully synthesized a compound that would eventually become globally recognized as Bayer aspirin. This was no serendipitous accident, unlike Alexander Fleming's discovery of penicillin, which famously resulted from mold spores drifting into his laboratory window. Instead, Hoffmann's achievement stands as one of the earliest and most exemplary instances of what is now termed Big Pharma at its best, systematically identifying a known natural remedy, modifying and recreating its active components in a laboratory setting, and subsequently commercializing it to broad public benefit. The efficacy of aspirin, or rather its natural precursor, had been recognized for an astonishing 4 millennia, not merely 50, 100, or 1,000 years, but 4,000 years. The ancient Sumerians, pioneers of early civilization, had already observed that by boiling the bark of the willow tree and consuming the resulting concoction, they could effectively alleviate fever and mitigate pain. It was precisely this long-established natural remedy that Felix Hoffmann sought to emulate and improve upon. Just a few years prior to Hoffmann's groundbreaking synthesis, the specific compound responsible for the willow bark's therapeutic effects was isolated and identified as salicylates. What Hoffmann ingeniously created was a more stable and potent derivative, acetyl salicylic acid. Now let's turn our attention to the mechanics of how aspirin functions. While one of its primary effects, and indeed the initial one noticed by the Sumerians and pursued by Hoffmann, is its ability to reduce pain, our modern interest largely centers on its other profound impact, its capacity to decrease blood clot formation. Aspirin achieves this by irreversibly binding to platelets, which are tiny, irregularly shaped cell fragments in your blood that play a crucial role in initiating the clotting process. By binding to these platelets, aspirin effectively prevents their activation, thereby hindering the very first step in the cascade that leads to a clot. It's important to differentiate aspirin's action from that of other classes of blood thinners, such as warfarin or heparin, and some natural alternatives. These agents typically exert their influence further down the clotting cascade, a complex series of about a dozen specialized proteins that interact sequentially to form a stable blood clot after platelets have initially formed a rudimentary latticework. Warfarin and heparin, for instance, are known as vitamin K-dependent clotting factors, specifically targeting factors the K2, 7, 9, and X. More recently developed novel oral anticoagulants, NOACs, such as Xarelto and Eliquis, are even more targeted, often focusing on inhibiting a single clotting factor, such as factor ZA. This brief foray into the biochemical intricacies helps illustrate the sophisticated mechanisms at play, and I appreciate your patience in navigating this somewhat technical or geeky explanation. Having established how aspirin works, we must now confront the critical issue of its side effects. The prevalent belief, often stemming from its over-the-counter availability, is that aspirin is inherently safe. However, this assumption is often misleading. Indeed, I often ponder whether, if the U.S. Food and Drug Administration, FDA, were to reevaluate aspirin and metformin today with a truly astute and unbiased perspective, they might conceivably designate metformin as over-the-counter and aspirin as a prescription drug. This seemingly radical thought underscores the very real, albeit often underestimated, risks associated with aspirin. Among its side effects, allergic reactions are a concern for some individuals. More commonly, aspirin can induce stomach ulcers and lead to gastrointestinal bleeding, a significant and potentially severe complication. However, the most critical side effect, and the one that primarily compelled the USPSTF to alter its recommendations, is the risk of bleeding bleeding in general. While gastrointestinal bleeding is by far the most frequent manifestation, there have been documented instances of bleeding in the brain, also known as intracranial hemorrhage, which carries devastating consequences. The previous USPSTF recommendation, prior to 2022, broadly advised that individuals aged 60 and older should take aspirin for the prevention of heart attack and stroke, presuming a general elevated risk in this demographic. My own recommendations, however, diverge significantly from this blanket approach. I consistently advocated for aspirin prevention only in individuals who had demonstrable evidence of plaque in their arteries, regardless of their age. Conversely, if no plaque was present, I saw no compelling reason to recommend aspirin, irrespective of age. I am naturally quite proud to note that the USPSTF eventually revised its guidelines to align with this very perspective. This fundamental distinction brings us to the crucial concepts of primary versus secondary prevention. The previous USPSTF recommendation fell under primary prevention, meaning it was advised even in the absence of any overt signs or symptoms of cardiovascular disease. Secondary prevention, in contrast, applies when an individual already exhibits signs or symptoms of an existing disease. The importance of this differentiation cannot be overstated. In primary prevention, the overall risk of developing the disease is generally lower. Once an individual has already manifested the first signs or symptoms of a disease, placing them in the category of secondary prevention, their likelihood of further disease progression becomes significantly higher. This understanding is key to comprehending the profound shift in the USPSTF's recommendations, moving from a broad primary prevention guideline to one primarily focused on secondary prevention. As I articulated, my personal and professional recommendation had always strictly adhered to secondary prevention, never primary. The rationale behind this shift was multifaceted. Significant advancements in cardiac disease management and a reduction in overall cardiac disease mortality rates in the general population meant that the benefits of aspirin for primary prevention, particularly in older individuals, were increasingly outweighed by its inherent risks, primarily the risk of gastrointestinal and brain bleeds. Thus, the USPSTF concluded that for individuals over 64 without established cardiovascular disease, the juice was simply not worth the squeeze when considering aspirin for primary prevention. However, this nuanced change was unfortunately misinterpreted by many, including prominent media outlets such as the New York Times. Even highly intelligent physician reporters sometimes failed to grasp the critical distinction, leading to headlines erroneously proclaiming that the USPSTF no longer recommended aspirin for cardiovascular disease prevention at all. This was a profound misrepresentation. They merely ceased recommending it for primary prevention. Aspirin continues to be recommended for secondary prevention. Compounding this confusion is the demographic reality that by the age of 60, a substantial majority of individuals already have some degree of arterial plaque, effectively placing them in the secondary prevention category, where aspirin often remains a viable consideration. This cascade of misinterpretation and lack of clarity has undeniably led to significant confusion regarding appropriate aspirin use. Let's consider a compelling real-world example to clarify this. What if you are actively experiencing a heart attack? Do current medical recommendations still advise taking aspirin in such an acute situation? Absolutely. In fact, in these critical moments, not even a baby aspirin, typically 80 or 81 milligrams, is advised, but rather a full adult-strength aspirin ranging from 160 to 325 milligrams. So, if you suspect you are having a heart attack, the two immediate and crucial actions are to call an ambulance for transport to the nearest emergency room or hospital, and to promptly chew and swallow an adult aspirin. This simple intervention continues to save a substantial number of lives. It might seem straightforward at this juncture, yet, regrettably, our broader culture has become profoundly muddled and confused by the changing guidelines. To deepen our understanding of secondary prevention, it's helpful to familiarize ourselves with specific terminology used by authoritative bodies like the American Heart Association. When defining secondary prevention, terms like previous heart attack, plaque in your arteries, whether in the coronary arteries supplying the heart or in peripheral arteries in the legs, and history of stroke are frequently employed. Two overarching patterns you'll repeatedly encounter are plaque and ischemia. While the definitions are important, don't get overly bogged down in them. Essentially, if you have demonstrable plaque, you should consider aspirin because you are now in the realm of secondary prevention. Ischemia, a term I also mentioned, refers to a significant reduction or complete cessation of blood flow, typically requiring 50% or more blockage of an artery. However, and this is a critical point, you should not wait for this level of blockage or for a stress test to indicate ischemia before considering baby aspirin if plaque is already identified. If plaque is present, the proactive use of baby aspirin is often warranted. Now, having used the term plaque several times, it's imperative to clearly define what it actually is, as common perceptions are often inaccurate. Most people envision plaque as a waxy or fatty substance coating the inside of an artery, specifically within the lumen where blood flows. Both of these widely held beliefs are, regrettably, incorrect. Plaque is not primarily a waxy substance, at least not in its dangerous, unstable form. It only becomes somewhat waxy when it stabilizes. The truly perilous plaque is a goop, akin to a mucus or snot, and it is critically characterized by being teeming with inflammation, inflammatory cells, and inflammatory liquid. It is this inflammatory goop that, when it ruptures or squeezes back into the bloodstream, triggers the formation of a blood clot. And it is this resulting clot, not necessarily the plaque itself, that causes the acute event. If the clot is large enough and travels to the heart, it precipitates a heart attack. If it reaches the brain, it causes a stroke. Furthermore, some individuals experience a continuous showering of microscopic levels of plaque into their bloodstream. Over months and years, this insidious process can silently contribute to the development of heart failure or even dementia, as the delicate tissues of the heart or brain progressively acquire a Swiss cheese appearance due to myriad tiny microscopic holes. This explanation helps us understand another crucial concept. The risk of such cardiovascular events does not solely depend on the amount or size of the plaque. You absolutely do not need a 50% blockage or more to be at risk. This takes us back to the concept of ischemia, which derives from a Greek word meaning stopping blood flow. Ischemia, by definition, necessitates a 50% or greater occlusion of the artery's lumen, the passageway for blood. However, and this is the vital common misunderstanding, you do not require that extensive level of blockage for a dangerous clot to form. While common sense might suggest otherwise, common sense is unfortunately incorrect in this specific medical context. A smaller, unstable plaque can be far more dangerous than a larger, stable one. Therefore, my direct and consistent recommendation is as follows. Who should genuinely consider aspirin? Irrespective of age, I advocate for baby aspirin, 81 milligrams. For any individual who has no known allergy to aspirin, has a low risk of bleeding, and, critically, possesses any objective evidence of cardiovascular plaque. If you have demonstrable plaque and are not precluded by allergies or specific bleeding disorders, then incorporating a daily baby aspirin into your regimen is a prudent consideration. This discussion inevitably leads us to address one of the most common yet frequently misused procedures in assessing heart attack risk, the stress test. It is remarkably prevalent for individuals to approach their doctor with concerns like, "My uncle had a heart attack and I'm a bit overweight. Why don't we just do a stress test to ensure I'm not at risk?" While this seems intuitively logical, it is fundamentally an ineffective approach for initial risk assessment. Stress tests, by their very nature, only reveal a problem if there is more than 50% occlusion of blood flow. Does that threshold sound familiar? We just discussed it moments ago in the context of ischemia. The Princeton Longevity Center, a respected institution in this field, has unequivocally stated that a staggering 2/3 of all heart attacks occur before an individual develops 50% occlusion of blood flow. So, Why do we continue to rely so heavily on stress tests for primary risk assessment? It's an unfortunate confluence of factors. It was once widely assumed to be effective by both doctors and patients, and perhaps more disturbingly, it has become a highly lucrative procedure for clinics and physicians, creating a powerful disincentive to cease recommending it. Leading organizations, including the American Heart Association and the American Board of Internal Medicine, have openly acknowledged that far too many doctors are performing far too many unnecessary stress tests. You might be wondering, with all these facts and nuanced explanations, what is my personal approach and what specific actions have I taken? I've shared my story in considerable detail elsewhere, and I'm happy to briefly recount it. When I first retired around the age of 53, I was introduced to two remarkable individuals, Brad Bale and Amy Doonan. They were traveling across the country, passionately educating people on their distinctive approach to preventing heart attacks and strokes. A central tenet of their methodology revolved around a specific test that was non-invasive, relatively inexpensive, and critically capable of detecting soft plaque, the truly dangerous, unstable kind. This test is called a carotid intima media thickness, CIMT test. At the time, I confidently believed I would ace this CIMT test. After all, I had diligently followed a low-fat diet for years and regularly participated in marathons, behaviors I assumed guaranteed arterial health, though I later realized some of those choices needed refinement. To my surprise and concern, the test revealed I did have plaque. Faced with this objective evidence, I made the conscious decision to begin taking baby aspirin. Concurrently, I undertook a deep reevaluation of my lifestyle and implemented several significant changes. A little while later, I discovered another crucial piece of my health puzzle. I had prediabetes. While the full narrative of my health journey is extensive, and we won't delve into every detail here, I can certainly direct you to other resources where I share that complete story if you're interested. Aspirin, without a doubt, is a life-saving medical tool, but its efficacy is not universal, and understanding when not to use it is just as vital as knowing when to deploy it. This brings us back to the critical issue of atrial fibrillation, or AFib. So let's explore AFib and its unique implications for aspirin use. In simplified terms, the human heart consists of 4 chambers. 2 upper chambers called the atria, and 2 lower chambers called the ventricles. The ventricles are the powerful workhorses responsible for pumping blood throughout the body. If they cease to function, life cannot be sustained for more than a minute or so. The atria, while not as muscular, play an essential supportive role by effectively loading the ventricles with blood, optimizing their performance. If the atria malfunction, the heart's overall efficiency can decrease by approximately 20%, which is certainly detrimental, but typically not immediately life-threatening, in the same way ventricular failure would be. Fibrillation, in the context of the atria, means that instead of the normal, coordinated electrical impulse and rhythmic contraction, the atrial muscle fibers begin to quiver chaotically and ineffectively in atrial fibrillation, while the ventricles usually continue to contract with a somewhat regular, albeit often rapid, heartbeat. The atria are merely trembling. The inherent problem with this quivering is that it significantly increases the risk of stroke, typically multiplying it by 5 to 8 times. Historically, many cases of stroke were categorized as cryptogenic, meaning their underlying cause was unknown. However, medical research is increasingly demonstrating that a substantial proportion of these cryptogenic strokes are now being attributed to previously undiagnosed atrial fibrillation. This brings us to the crux of the matter. Why is aspirin ineffective for preventing strokes caused by atrial fibrillation? The precise mechanism remains somewhat elusive, but a prevailing hypothesis suggests that the clots formed within the quivering atria are fundamentally different in nature from those aspirin typically targets. These AFib-related clots are believed to form in stagnant blood pools within the atria, particularly in a small pouch called the left atrial appendage, and for reasons not fully understood, they are simply not susceptible to the antiplatelet mechanism by which aspirin works. Therefore, aspirin is largely considered an ineffective preventative measure against AFib-related strokes. I, personally, have paroxysmal atrial fibrillation, meaning it occurs intermittently, coming and going. The vast majority of AFib cases, in fact, are of this paroxysmal type. AFib shares a striking parallel with prediabetes. For a long time, we knew many people had it, and that it contributed to a significant number of deaths. However, it wasn't until more widespread testing and awareness campaigns that we began to fully grasp its true prevalence, recognizing that as individuals age, a majority will likely develop some form of it. The same awakening is occurring with AFib and its profound link to stroke risk. We've long understood that AFib is a leading individual cause of strokes and that it is by far the most common heart rhythm problem, with its prevalence increasing dramatically with age and in individuals with conditions like prediabetes and diabetes. Yet, for many years, we had no clear estimate of how many people actually harbored atrial fibrillation. While we still don't have definitive numbers, continuous monitoring and diagnostic advancements are revealing a far greater prevalence than previously imagined. Returning to my personal AFib story, it was approximately 5 years after I began taking aspirin, so around ages 55 to 57, following my initial CIMT test, that I discovered I had AFib. This discovery was facilitated by using a home monitoring device called an iCardia, which, along with similar devices readily available online, including features now integrated into Apple Watches, offers an affordable means of cardiac rhythm assessment. For years prior, I had occasionally experienced palpitations, leading me to suspect the possibility of AFib. Further reinforcing this suspicion, genetic testing had indicated I carried a specific genetic variation, 4q25, known to increase the risk of AFib. My history as an endurance athlete also paradoxically elevates AFib risk, and my later diagnosis of prediabetes added yet another layer of risk. One night, after acquiring my iCardia device, I awoke to a sensation akin to a fish vigorously flipping in my chest. My pulse was a rapid 150 beats per minute and distinctly irregular. A pulse between 100 and 200, particularly if irregular, is a strong indicator of atrial fibrillation. It was 2 a.m., and armed with my knowledge of multiple AFib risk factors and previous palpitations, I quickly used the iCardia device, which confirmed my diagnosis of atrial fibrillation. While I won't delve much deeper into my comprehensive AFib journey here, please indicate in the comments if you'd be interested in a more extensive exploration, as I do have a series of dedicated videos on the topic. And for those who might think AFib won't affect them, just as some dismiss the risk of prediabetes, I urge a reconsideration of that perspective. Given that aspirin is ineffective for preventing strokes in individuals with AFib, what does work? The answer lies in a class of prescription medications known as novel oral anticoagulants, or NOACs. These are a newer generation of prescription blood thinners that are demonstrably superior to aspirin for AFib-related stroke prevention. NOACs exert their therapeutic effect by inhibiting specific factors within the coagulation cascade, such as thrombin or factor XA, components I briefly mentioned earlier as proteins that solidify a clot after platelets have formed an initial framework. Common brand names for these NOACs, which many viewers may have already encountered, include Xarelto and Eliquis. Earlier, I promised to address natural options for blood thinners, a topic of considerable interest for those who prefer to avoid prescription medications. It's important to acknowledge that prescription drugs, by their very nature, carry inherent risks, and NOACs are no exception. While they are powerful tools, they too have potential side effects. However, a deeper analysis might even suggest that some NOACs carry less overall risk than aspirin, a discussion for another time perhaps. Regarding natural alternatives, several have demonstrated antiplatelet or anti-clotting properties. Fish oil, rich in omega-3 fatty acids, for instance, is known to decrease the stickiness of platelet membranes, which is why it's often cited as a natural blood thinner. Serrapeptidase, or serrapeptase, is an enzyme that helps break down fibrin, a key component of blood clots. Other natural substances such as ginger, garlic, nattokinase, and turmeric all exhibit various antiplatelet functions. I personally incorporate many of these into my regimen, and they undoubtedly offer health benefits. However, and this is a crucial point that many may find unpalatable and which often draws criticism, these natural options, while beneficial, are unequivocally not superior to prescription medications, especially when it comes to the critical and serious business of preventing strokes in AFib or preventing heart attacks and strokes generally, where aspirin or other prescription anticoagulants are indicated. Preventing heart attacks and strokes is a matter of profound seriousness. My patients, and indeed I, have come to believe that stroke prevention carries an even greater weight of seriousness than heart attack prevention, primarily because stroke is the leading cause of permanent disability, often consigning individuals to a lifetime in a wheelchair or bedridden state. Therefore, it is simply not advisable to gamble with either heart attack or stroke prevention using less effective alternatives. I readily admit that this entire subject matter can be intricate and at times confusing. If you are seeking medical care that embraces a holistic approach, one open to diverse treatment modalities, firmly rooted in lifestyle interventions, and acknowledging the vital roles of both medications and supplements, then I encourage you to consider our practice. We fundamentally believe that while medications and supplements are important tools, nothing surpasses the profound impact of lifestyle modifications in preventing heart attacks and strokes. The lifestyle components we consistently advocate, such as diligent weight management and proactive screening for and management of prediabetes, remain the cornerstones of prevention, even overshadowing the effectiveness of aspirin or NOACs alone. If you feel overwhelmed or unsure how to effectively implement these changes, we are here to guide you. Our approach is intentionally non-paternalistic. We deeply respect and support your personal decisions concerning your health journey. To use a cinematic analogy, think of yourself as Luke Skywalker. I merely serve as Yoda. Just as Luke had to fight his own battles, you must make your own informed decisions and navigate your personal battles against heart attack and stroke. For instance, if you express, "I can't lose weight," or "I don't want to lose weight," I will listen with understanding and offer support in every conceivable way. If you acknowledge having plaque but state, "I don't want to take aspirin, I'd rather take turmeric," I comprehend your choice. My role is to ensure you are fully apprised of all the pertinent details, but I will nonetheless support your decision. Even in the serious context of AFib, if you articulate, "I don't want to take one of those prescription NOACs, I'd rather take baby aspirin," I respect your autonomy. My commitment is to provide you with all the necessary information, the benefits, the risks, the evidence-based knowledge, and to openly share what I would personally do or have done in similar circumstances, while ultimately supporting your chosen path. If you are interested in exploring care with us, please refer to the description below the video for a link or contact information. Finally, I mentioned earlier a topic I hadn't fully elaborated on: LPA, or lipoprotein A. Many perceive LPA as a novel cardiovascular risk marker, but in reality, it has been recognized for a considerable time. The reason it has historically been overlooked by most physicians is quite straightforward. Until recently, there was little known about how to effectively manage elevated LPA levels, leading most practitioners to simply not test for it, or even to remain largely unaware of its significance. This began to change a few years ago when Bob Harper, the well-known trainer from The Biggest Loser, suffered a heart attack. His case was particularly surprising because he was in his early 50s and remarkably fit, seemingly a paragon of health. As the public questioned what could have led to his cardiac event despite his exemplary lifestyle, Bob openly disclosed that he had elevated LPA, an inherited condition passed down from his mother. LPA is structurally similar to LDL cholesterol, often referred to as a cousin lipoprotein, but it is a distinct genetic variation. Critically, elevated LPA can increase the risk of heart attacks by up to 4 times. Intriguingly, aspirin has been shown to significantly decrease the increased risk of heart attack and stroke, specifically attributable to LPA. You have been exceptionally patient throughout this comprehensive exploration, and if you have persevered to this point, I extend my sincere appreciation. My hope is that you now possess a far deeper understanding of how aspirin functions, its profound benefits, its associated risks, and the critical distinctions of when its use is appropriate and when it is not, particularly in the nuanced context of atrial fibrillation. You are also now better informed about AFib itself and the emerging importance of LPA in cardiovascular risk assessment. While I am a strong advocate for lifestyle as the primary and most powerful intervention for cardiovascular health, I also recognize and utilize medications judiciously when appropriate and desired by the patient. Supplements play a supportive role, and we remain knowledgeable about their applications as well. Should you be interested in learning more about how I personally approached and reversed my own arterial plaque, I encourage you to click on the linked video. If you wish to explore becoming a patient, please use the link provided in the description. Thank you immensely for your sustained interest and engagement.